Hello everyone, Dr. Akshaykumar Kamble here, consultant neuroradiologist. I'll be taking another mock exam today. Yeah. So patient presented with the his history of lump, and this is the scan you have.
Uh, wait.
Can you see it?
Uh, oh yes, I can see it. It's a T1 axial MRI sequence of both breasts.
Mm-hmm.
Um, okay, I noticed on the lateral quadrant of the breast there is T1 hypointense lesions
Mm-hmm.
in the right breast. There's no enlarged lymph nodes. There's adjacent architectural distortions. I would also like to look for the contralateral breast to see if any mass of architectural distortions. The lesion is away from the underlying pectoralis muscles and also away from the superficial skin. It has lobulated borders, and it is heterogeneous. I would like to also look for the dynamic sequence to see if the enhancement pattern of these lesions.
So you're sure it is T1, yeah?
Yes.
Can it be T2?
T. Uh, um, can be T.
It's in the breast. It's difficult to comment whether it's T1 or T2 unless you have given they have given you what in the label. Yeah. So this is a T2 sequence here. Now I'm showing you the stir sequence because there is a lot of fat there. So both T1 and T2 will have the same intensity of fat. So unless they have given you what kind of sequence it is, it's difficult.
This is stirred coronal view,
Mm-hmm.
which again there's the right lateral breast lesion appear to be hyper intense and has speculated margin. This is worrisome of the neoplasm, and there's adjacent architectural distortions, and I can't see any axillary lymphadenopathy, and there's no similar lesions in the contralateral breast. For these lesions, I would like to correlate with the mammogram and also the breast ultrasound if patient has previous imaging.
That is stir axial, yeah.
Um,
And what is this sequence?
this is the DWI sequence. I will compare with the ADC map. So it appears to be hyper intense. I will look for the ADC to see if any corresponding hypo intensity at that area.
So we don't have the ADC, but you can consider that is a showing low ADC value.
So there is an ill-defined speculated margin, lesions in the right lateral breast with restricted diffusion, and I'll check for the dynamic sequence to see if it has a abnormal dynamic curve that will suggestive of malignancy. If so, then I will go back to have a second ultrasound. If there's a confirmed lesion, then I suggest this patient to undergo ultrasound guided biopsy. Otherwise, that MRI guided biopsy would be another feasible method. So this is the dynamic sequence.
Yeah.
I can see the lesion is enhancing. The enhancement pattern appear to be more severe than the contralateral left breast. So I think this is abnormal. I look
One,
for
one,
the.
oh, one second. Yeah, let me put the scan first. Yeah, can you see it now?
Oh yes, I can see it. It it's highlighted as a green in the color map, right?
Yes.
Then uh, so the dynamic pattern. Hmm, hmm. Oh, sorry, I'm not sure which one is the ABC, which one corresponding to the lesions.
So this curve is corresponding to the lesion.
No, the
Yes.
A will correspond.
Yes.
So it initially
So
rise and then
forget
it.
forget about this. No one is going to ask you about
Mm,
the actual objective parameters. What is this curves called? Do you know the name of these curves?
uh, uh, dynamic.
The
Um,
Coles curves. Yeah. There.
uh,
So there are three types of curves: type one, type two, type three, depending on how is the washout. You can read more about that. Yeah. But this is showing early enhancement and a bit of a washout.
watch out.
That is that lesion showing the speculated margin. It was a difficult case, but yeah. So what would you say? What would you do the manage as a management?
I think this lesion is suspicious of malignancy,
Mm-hmm.
given the abnormal dynamic curve, and I would
Mm-hmm.
suggest this patient to have ultrasound to have a second look to see if this lesion can be detected through ultrasound, and then I would suggest biopsy for this lesion and refer this patient to the breast MDT meetings.
Good.
Uh, this is the AP view of the left shoulder. I see the left humeral head is inferiorly displaced. Ideally, I would also like to look for the wide angle view to see uh, if it is for lateral view. I can see that the humeral head is not in congruent position um, with the glenoid. So this confirms this is left humeral shoulder, left humeral head dislocations. And I noticed there's a depression in the superior lateral border of the humeral head. And I would take closer look to see if any glenoid depression or fracture, which there's a little bit cortical irregularity at the inferior glenoid, which I suspect that can be Bancroft.
Here you mean?
Here, here a bit. Maybe I'll go back to the AP view to see if any. I'll look for the Bancroft lesions.
Mm-hmm.
Yeah, I see there's a tiny bony fragment at the inferior borders of the
Yeah.
glenoid.
Very good.
Yeah, so there's otherwise there's no pneumothorax. I can't see any displaced rib fractures. So the AC joint is in normal position. So in summary, this patient presented with right shoulder pain. So radiograph finding confirms anterior inferior dislocation of the left humeral head, and also there's associated Bancroft lesion in the glenoid. And I will urgently inform the referring clinician this patient needs to have shoulder reductions,
Okay.
and probably an MRI can be helpful to delineate about.
What is this view? Is this the Y view you were asking?
This is not a Y view. I think
Okay.
it's.
But it's not a lateral view either, is it?
Yeah.
Yeah.
I think the angle is from the inferior tilted cranially.
Yeah. Have you heard of something like a axillary view?
Axillary.
Yes.
No.
Yeah. But yeah, what complications you can get with this?
It can cause compression of the neurovascular bundles, and it can cause the compression of the axillary nerves and also the arteries.
Okay.
And in long run, that the bankrupt and hillside lesion can cause degenerative changes, and patient may prompt to recurrent dislocations.
Okay. Good. So you did good, especially on the MSK case. It was very nicely described and succinct points. In the breast case, once you can ask them which kind of sequence it is, because see this is T2,
Mhm.
so this is T1,
Mhm.
and this is T2. So you see, it's very difficult to comment
Oh yeah,
what is.
it's very similar.
Yes, they
Mhm.
are very similar looking because of the fat around.
Mhm.
You don't have any water intensity structures around usually in the breast, so that you can say that if it is hyper, it's T2. Unlike in the brain, you have CSF to easily say it is T1 or T2, but here you have mostly fat. And why it is important to know whether the lesion is T2 hypointense?
Uh, if it is hyper intense in T2, then that is.
Hypointense something.
Mm.
That means it's more cellular. Yeah, if it's hypointense on T2, it's more bit more cellular, and that's why, because if you have something like a cystic lesion, it will be hyperintense, like simple cyst, even fibroadenomas, they will be
Mhm.
more hyperish compared to the neoplasm. What other things I would you were describing, like architecture distortion, you could also have commented more on the speculations, even though you said that it is microlobulated, but there are some definite speculations there on T2. Yeah.
Mm.
So speculations really goes towards malignancy because it causes the surrounding architecture distortion. Diffusion, you picked up nicely that it is showing diffusion restriction. Most of the breast cancer, they will show diffusion restriction. Yeah. And then finally, coming to the dynamic scan. So in dynamic scan, it's a bit like a brain. You will always have this scale on one side, so which is going from the blue to red. So you see the heart and everything, liver also, it will show the moderate perfusion. You see this lesion is also showing moderate perfusion, but there are some areas, especially around spicules, you see, they are reddish, that
Oh
showing
yeah. Mhm.
higher perfusion. Yeah. And this is called Cool's curve, and you place it in the lesion and you see whether it's showing early wash in and wash out. So usually a tumor or something, they will have just, can you see my pen now?
Yeah. See your pointer. Yeah.
Yeah, like,
Yeah.
so usually when you place it in the tumor, you can have something like this. So that's rapid wash in and wash out. You can see the
Yeah.
pointer. Yeah.
Yeah.
And if you have something like this and then plateau, so that could be also malignant. Yeah. And
Mhm.
then you have something which continues to rise, that you
Yeah.
call not malignant. So there are three types of curves, you can read more about them. They're called Cool's curve. Yeah, so that's why you do the dynamic here. So yeah, so this breast was difficult case because usually you don't see the breast MR that much in your routine thing, and you also need to know that in UK they use a different system than BIRATS. So need to read a bit about it if they ask.
Yeah.
But your management, how you said that you will refer it to the MDT, and that was spot on. So well done.
Thank you.
Yeah, keep up the good work. Yeah.